Good morning, everyone. I am Eric Lufer, the president of the Citizens Research Council of Michigan. I'd like to welcome you to today's webinar offering perspectives on what public health means for Michigan. We published a paper last week on Michigan's public health system. The paper explains the difference between public and individual health programs and describes the importance of a vibrant public health system. It goes into a recent history of state funding for public health and describes the health status of Michigan's population as a whole. It is an unhealthy status that very much reflects the state's failure to invest in this important public service. Today we're going to go over the highlights of that paper and help you understand this service so that you can ask your candidates for governor, the legislature, and other important positions how they're going to take actions to address this issue. The Citizens Research Council is a statewide, nonpartisan public affairs research group. This is the Citizens Research Council's 102nd year of operation, a longevity we attribute to our promotion of sound public policy for state and local governments through accurate, independent, and objective research. We are a private, not-for-profit entity, and we rely on charitable contributions of foundations, businesses, individuals, and corporations. I'd like to encourage all of you to join our circle of supporters and help us to continue to provide high-quality, independent information on important policy topics in Michigan. You can learn more about the Research Council at crcmich.org, crcmich.org. At the right of the website, towards the bottom, you'll find an opportunity to sign up for our email distribution list to be notified about newly released papers. We welcome you joining our list. Our presenter today is Tim Michling. Tim has been with us for a couple of years now, doing great work in health and research on health policies. His December paper on Medicaid expansion in Michigan, termed Healthy Michigan, provided concrete information for policymakers to understand the benefits of the program to participants, employers, children, and the state as a whole. He has continued that great work with his look at public health. Before moving on, I wanted to note that these slides that you'll be seeing will be available on our website at the end of the webinar. And we are recording this webinar and we will post it to our webpage as well after it takes some time to process it and post it up on YouTube. Second, I want to let everyone know that we have everyone but the presenter on mute, so we will not be able to hear you if you speak. The GoToWebinar technology, the interface, has an opportunity to ask questions through that, and we encourage you to use that opportunity to ask questions, and we'll have a question and answer period at the end of the webinar. If you have any technical problems during the webinar, please let us know by calling 734-542-8001. And also, after the webinar, you'll receive an email soliciting your feedback, and we'd very much appreciate any thoughts you have. With that, let me turn things over to Tim.
Thank you very much, Eric, and thank you for everyone who has tuned in for today's webinar. To begin to talk about public health, I think it's important to ask the question, what is public health? And it's important to ask that question because surveys have shown that the public often makes the mistake of thinking that public health refers to government-sponsored health insurance programs like Medicare, Medicaid, and CHIP. Others might think that public health relates narrowly to a handful of typically visible activities, such as immunizations. In reality, however, public health evokes a constellation of policies and programs focused on improving the health of populations. The frequently used saying in public health is that medicine helps people one at a time, whereas public health helps entire communities. Public health generally utilizes the World Health Organization's conceptualization of health as a state of complete physical, mental, and social well-being, and not merely the absence of disease. In addition to this population-level focus, public health is concerned with prevention, that is, in a general sense, stopping diseases and other forms of harm from occurring. We can think of prevention in multiple levels. Primary prevention is typically proactive activities that seek to prevent diseases from ever occurring. So the classic example of immunizations, as well as factors like smoking cessation or improved lifestyle that might stave off heart disease or cancer. Secondary prevention is reactive prevention that's happening after a disease has already occurred. So the classic example here would be health screenings that detect a disease early in its preclinical phase and then halt the pathogenesis of that disease. Tertiary prevention might be best thought of as mitigation. This is an intervention in later stages of disease once there are clinical symptoms. And the focus of tertiary prevention is really to limit disability, impairment, and or pain. Beyond these three levels, there's an increasing interest in what is being called primordial prevention, that is something coming before primary prevention. These are early interventions that address risk factors associated with the development of disease, often focused on social, environmental, and behavior factors. So whereas primary prevention tries to stop diseases from occurring by removing harmful exposures and risk factors, as well as deploying and developing immunity, primordial prevention generally looks at the circumstances surrounding those risk factors to prevent the undesirable risk factors from happening in the first place before future disease is even a concern. So rather than preventing heart disease by adjusting lifestyle, the concern in this case would be preventing the development of obesity by addressing lack of healthy food options or lack of nutritional knowledge. Public health is made up by what are called the three core functions, and these were first outlined by the Institute of Medicine, which is now the National Academy of Medicine. These three core functions are assessment, policy development, and assurance. Assessment describes the process of monitoring and determining the health status of populations by way of health screenings, testing for environmental hazards, observing the incidence and prevalence of various health conditions, tracking infectious disease, monitoring health disparities, surveying air and water for evidence of bioterrorism or chemical weapons. Policy development describes the process of constructing new interventions to improve health, establishing goals and standards for health service delivery and population health, and setting priorities for the distribution of health resources. Assurance describes the implementation and evaluation of programs and services, the guarantee of quality and safety, such as through licensure or inspection, and the education and empowerment of the public to self-manage health with the goal of assuring that all health needs are effectively and safely met. The 10 essential public health services, which in the figure shown can be seen to fit into the three core functions of public health, are things that were adopted by the Centers for Disease Control and Prevention in 1994. These essential public health services describe the public health activities that all communities should undertake. That is to monitor health status, to identify and solve community health problems, diagnose and investigate health problems and health hazards in the community, inform, educate, and empower people about health issues, mobilize community partnerships and action to identify and solve health problems, develop policies and plans that support individual and community health efforts, enforce laws and regulations that protect health and ensure safety, link people to needed personal health services and assure the provision of health care when otherwise unavailable, assure competent public health and personal health care workforce, evaluate effectiveness, accessibility, and quality of personal and population-based health services, and research for new insights and innovative solutions to health problems. These core functions and essential public health services share a core value of health equity, which is a primary uniting concern of all public health practitioners. Health equity is the pursuit of the highest level of health for all people. This means providing a guarantee of equal opportunity, preventing factors that can harm health, like unsafe water, air, food, and generally hazardous environments, and empowering people with knowledge, skills, and support necessary to manage their health. A focus on health equity helps to reduce health disparities that can occur across class, race, geography, and various other personal characteristics. For instance, the Citizens Research Council report on Michigan's urban-rural divide highlighted that Michigan's rural areas have, on average, worse health than the state's urban areas. We also found that when stratified by race, health outcomes were worse among Black residents of the state when compared to white residents or Asian residents. More on health disparities later in this presentation. Lastly, public health is generally regarded as a public good. In economic terms, that means that most public health services are both non-rivalrous and non-excludable. Non-rivalrous means that consumption by one person doesn't prevent simultaneous consumption by others. So my breathing of clean air doesn't reduce your ability to breathe clean air as well, at least as long as I brush my teeth and I'm not a close talker. Non-rivalrous also means that usage by one person doesn't reduce utility of the good or wear it out. In fact, in the case of public health, producing goods like herd immunity, utility is actually increased by group participation. When we say non-excludable, that means that one cannot prevent access with fees or payments. So clean air is the classic example of a non-excludable good. Even if someone in a community doesn't want to pay for clean air, they'll still enjoy it if the rest of the community pays for it and has a clean environment. The general point is that public health benefits everyone and has traditionally relied on government to play a central leading role in its delivery as a public good. So here we provide some general categories of public health services that are traditionally provided by government, such as infectious disease control and prevention, chronic disease control and prevention, which is an increasing role, food safety and quality, environmental health, health facility and professional licensure, emergency preparedness and response, and health promotion and the reduction of health disparities. It's important to note that these are general categories and really many things can be seen to cut across them. So foodborne illnesses can also turn into infectious disease epidemics. Environmental health factors can lead to chronic disease over the term of a person's life. But in general, this means that public health in Michigan works to ensure that infectious diseases are monitored and contained, drinking water is safe, air is clean, sewage is contained, grocers and restaurants provide safe, untainted food. Sources of foodborne illness are identified and investigated. Healthcare emergency response plans are in place for natural and human-made disasters. Children are vaccinated to protect against diseases. Screening programs are available to identify possible health risks. Healthcare services are accessible for segments of the population, all segments, and the underlying causes of disease and injury, including social factors, are identified and addressed. So what do we get for all of this? Added years of life for one thing, as well as a better quality of life. Average life expectancy in the mid-19th century was just 39 years at birth. That's half of what it is today. A survey found that most people attribute this increase to improvements in medical care and advancing medical technology. In reality, however, the vast majority of these added years of life are due to public health. Early interventions in water quality, food safety and nutrition, sanitation and waste removal, and reductions in infant and maternal mortality through public health had a huge impact on life expectancy around the turn of the 20th century. Subsequent public health endeavors like infectious disease control techniques and improved social conditions in communities have made further improvements to the length and quality of life. There's certainly been an increasing role for medical care in the later part of the 20th century that continues today in increasing our length and quality of life. But it would be short-sighted to believe either that public health has fulfilled its contributions to human health and well-being and has nothing left to give, or to believe that we can take past advances for granted without maintaining public health systems that continue to provide benefits like safe foods and environments. These safe foods and environments don't happen without investment, however. So now that we've defined public health, we turn our attention to quantifying Michigan's investment therein. While Michigan formerly had a Department of Public Health, The core of that department has then become the former Department of Community Health and has subsequently been placed within the present Department of Health and Human Services as the Population Health Division. We begin our fiscal analysis by looking at public health expenditures, therefore, within the Michigan Department of Health and Human Services budget. Here, we present 5 years of recent expenditure data. These data come from the Michigan State Budget Office. We can see funding is spread across several areas: public health administration, health policy, laboratory services, infectious disease control and epidemiology, chronic disease prevention and health promotion, and family, maternal, and children's health, as well as support for emergency planning and disaster preparedness and support for locally delivered public health services. It's important to note in the funding shown that WIC funding, which might be considered part of family, maternal, and children's health, is excluded because this is a federally funded program. There's a trend of recent growth, but this growth is isolated in 3 major areas. Family, maternal, and child health had a 25.7% increase over the period. Infectious disease control saw a 21.7% increase in investment. And investment in local public health increased by 15.7% over these 5 years. Little new investment in chronic disease prevention and health promotion, emergency preparedness, the state lab, or health policy is seen. Moreover, a 20% reduction in funding for vital records and health statistics, which underpin a lot of public health research, has occurred since fiscal year 2008. Taken in total and looking over the past 15 years, we see somewhat flat funding. Adjusted for inflation using the average CPI for each state fiscal year 2017 expenditures are $20 million below expenditures in fiscal year 2003. In these 2003 dollars, public health expenditures have dropped by 16% from the inflation-adjusted high point that can be seen in 2004 of $300 million. These expenditures, of course, make up just a fraction of the state budget. Even if not for the inflation-adjusted decline, however, public health funding might be considered inadequate, and we can see this inadequacy on the current chart that illustrates the inadequacy by means of comparison. Here we look at state public health funding data for the most recent year, fiscal year 2017, across all 50 states plus Washington, D.C. Comparison across states is admittedly difficult, given differences in public health delivery and categorization that happens between states. To make a comparison, we draw on data from Trust for America's Health that looks at funding for state health departments, eliminates federal funds, and then strips away all programs that are mainly federally funded or that might not be considered public health, so Medicaid or WIC. We're left with state investment in population health services and programs. Using these criteria, Michigan ranks 43rd for its per capita state investment in public health at just $12.92 per person. Michigan, in this regard, is much closer to Mississippi at $12.26 per person than it is to Massachusetts at $53.47 per person, or Minnesota at $64.89 per person. As mentioned previously, public health is not just restricted to immunization and chronic disease management, but includes a broad range of concerns from environmental health to food safety to health professional and facility licensure. These services were once the purview of the Department of Public Health, but they are now performed by multiple state agencies, and this has occurred after several subsequent executive reorganizations of state functions. Public health has grown from a cluster of sanitation, maternal health, and disease control services to its present incarnation, which cuts across all areas of policy, including education, corrections, arts and culture, parks and recreation, transportation, and economic development. We will only consider the 5 primary agencies, including Health and Human Services, that have the most clearly defined public health responsibilities. So those include the Michigan Department of Agriculture and Rural Development, the Michigan Department of Environmental Quality, the Michigan Department of Licensing and Regulatory Affairs, and the Michigan State Police. Here we see appropriations for the Michigan Department of Agriculture and Rural Development over a 5-year period. MDARD performs many traditional public health functions, most notably food safety. Funding for the Food and Dairy Division administers Michigan's food law, protecting the population from foodborne illnesses, adulteration of food products, as well as fraud and deception in the sale of food products. Animal industry activities are included in this analysis because they're focused on detecting and eradicating animal diseases, some of which could also threaten human health. It's important to note that half of the division's activity is for bovine tuberculosis containment in the dairy and beef industry. Appropriations units for fairs and exhibitions and agricultural development have been excluded from this analysis given their separation from public health. So we can see that appropriations have grown steadily over the past 5 years. But it's also important to note that even at the line item level, it's difficult to completely assess the proportion of dollars used for public health versus those in support of industry in agriculture. Here we have DEQ appropriations over the past 5 years. The Department of Environmental Quality took over numerous regulatory programs when it was created in 1995, including air quality, water quality, underground storage tanks, and waste management. The DEQ also performs environmental investigations and cleanups. Because of the importance of environmental health and the fact that poor environments can account for as much as 25% of global mortality, we have included all DEQ funding in this analysis, reflecting its importance for human health and well-being. Here, taking these appropriations for MDARD and DEQ, incorporating line items from the Department of Licensing and Regulatory Affairs and State Police, and including fiscal year 2018 appropriations for public health in the Department of Health and Human Services, we come up with a total of around $1.4 billion in public health funding, which amounts to approximately 2.5% of the total state budget. This is a more robust estimation of public health investment than we see solely in the Department of Health and Human Services, but it's still just a fraction of what is invested in other core areas of state government responsibility, such as schools and roads. Without considering local health departments, however, we can't capture the totality of public health spending in Michigan. Counties were granted the authority to establish local health departments in 1927, and these health departments grew throughout the mid-20th century. By 1966, all counties were being served by full-time health departments. Michigan's Public Health Code, adopted in 1978, maintained the autonomy of these existing local health departments and granted them key public health responsibilities. Today, there are 45 local health departments in Michigan, some serving multiple counties and one serving the city of Detroit. Given the importance of community-level factors in health, local health departments still fulfill a very important role. While local health department funding was not the focus of this report, we did consider state appropriations for essential services provided by local health departments. Local health departments, of course, also receive funding from local units of government through fees, from grants, and from private sources, and these funding sources do not pass through the state budget. Section 2475 of the Public Health Code specifies that the state will reimburse entities for 50% of the cost of providing required and allowable health services. This funding for essential local public health services has remained flat over the past 15 years, and adjusting for inflation, this represents a roughly 20% reduction in investment over the period. So, why don't governments invest more in public health? There are probably a number of answers to that question. One is the lack of support and understanding by the general public discussed earlier in this presentation. That leads us to need to ask the question, what is public health? Public health is also often invisible when done right. but everyone notices when something goes wrong, like an environmental catastrophe or a disease epidemic. There's also a tendency of governments to pursue short-term solutions and think in limited time horizons. And in contrast, public health is really a long-term investment in public good. There's also a general libertarian streak in American politics that cuts across parties. There's a preference for individually determined lifestyles and an anti-regulation sentiment that may run across the grain of public health's recommendations for healthy lifestyles or desire to regulate industries to reduce pollution, for instance. And lastly, it might just be that public health professionals are no fun at parties. After all, these are the people that tell you not to drink, not to smoke, to avoid the fried food, the red meat and processed meat, and to eat your veggies. It's often said that appropriations run Lansing, but money isn't the only kind of investment. In fact, fiscal appropriations, so much as they're either discretionary or structurally designated with intent, are political statements. They're reflections of social, intellectual, and philosophical investment. In other words, we don't spend money on things that we don't choose to prioritize or that we don't believe are important. Because there's a broad lack of understanding among the public regarding public health and its importance, this leads to individuals underestimating public health's importance and value. So part of the solution to Michigan's lack of investment isn't only fiscal, but it's also social and political. Our paper identifies a few structures and concepts that may help Michigan place greater importance on public health. Health in all policies is an approach that is a strategy for addressing the complex factors that influence health and equity and preventing harm to the population. So this seeks to create a collaborative approach to public health and to broadly incorporate public health perspectives into policy formulation and implementation across government. A Health in All Policies guide for state and local governments was created by the American Public Health Association, the Public Health Institute, and the California Department of Public Health in response to growing interest in using collaborative approaches to improve population health by embedding health considerations into decision-making processes across a broad array of sectors. The guide draws heavily on the experiences of the California Health in All Policies Task Force and incorporates information from the published and gray literature and interviews with people across the country. We can see health in all policies being adopted in other states like Virginia, Massachusetts, and Washington. Public Health 3.0 was a call to action to create a 21st century public infrastructure. So we see Public Health 1.0, 2.0, and 3.0 here, and these numeric designations are really terms of art that were developed by the U.S. Department of Health and Human Services to conceptualize public health's history in three distinctive paradigms, two past and one future. Public Health 1.0 looks at the period around the turn of the 20th century when we established basic sanitation, population health, food safety, and other standards, and when states like Michigan started their first boards of health and departments of health. Public Health 2.0 encapsulates the period when Michigan adopted its public health code in 1978, as well as the subsequent development of the core values and essential services of public health. Public Health 3.0, by contrast, suggests a new strategic paradigm that focuses on collaboration across sectors and has the intent of overcoming health inequalities and inequities. It suggests that chief health strategists must step up to form key partnerships across sectors and jurisdictions in government, as well as the private and nonprofit and philanthropic sectors. Dr. Karen DeSalvo, former Assistant Secretary for Health, stated, "Our collaborative action must ensure for the first time in history that every person in America has a truly equal opportunity to enjoy a long and healthy life. The initial steps we take to get there are outlined by Public Health 3.0. So what can we say about Michigan's lack of investment other than pointing out that there's a corresponding cost to this lack of investment that limits Michigan's ability to respond to emerging threats or to innovate to address new public health challenges. While the best funding and structures for public health are certainly open to debate, the need for public health in Michigan is abundantly clear. Michigan has the 8th highest rate of death due to heart disease, the 15th highest rate of death from cancer among states, and exceeds national averages for deaths from a litany of causes. A third of adults in Michigan are obese, 1 in 5 smoke or use tobacco. Infant mortality in Michigan exceeds the national average, and residents in Michigan have a shorter average life expectancy at birth. Anyone who reads the news will see the resurgence of vaccine-preventable diseases like measles, mumps, pertussis, PFAS contaminations in water supplies, harmful algal blooms in the Great Lakes, emergent diseases like Ebola, Zika, SARS, MERS, and of course you'd have to live under a rock to have not seen the international attention paid to Flint and its ongoing water emergency. In contrast, however, our healthcare system in Michigan tends to rank fairly well, particularly on measures of cost and access. In addition, a greater proportion of Michigan residents have health insurance than the national average. However, clinical care represents only a fraction of health outcomes. These outcomes are predominantly determined by health behaviors, social and environmental factors, and physical environment, all of which are intertwined. These, of course, are modifiable health changes. As the population ages in Michigan, addressing the growing burden of chronic diseases may become public health's most economically impactful purpose. As well, depression is a leading cause of disability and other social harm and individual harm, and public health perspectives on depressive disorders will become increasingly important in the future. All of this focus on social and structural factors leads us to conclude that a person's zip code has become a stronger determinant of their health than their genetic code. And when we look at risk factors for disease like obesity, it's strongly associated with poverty and related stresses, as well as social and behavioral norms. If we look at smoking, it's strongly associated with socioeconomic position. So we can consider smoking prevalence stratified by educational attainment, and we see that for individuals with less than a high school education, 41.1% smoke. For people that have attained a high school education, that's 26.9%, and for those with a 4-year degree or higher, the smoking prevalence drops to 7.5%. Infant mortality varies substantially by community as well. Michigan's infant mortality rate of 6.4 deaths per 1,000 live births is certainly higher than the national average, but part of that is due to factors like Detroit having an infant mortality rate of 12.7 deaths per 1,000 live births. It's not solely a urban concern, because rural counties have infant mortality rates in excess of Detroit, like Presque Isle County with 14.7 deaths per 1,000 live births, and that's a 5-year average to account for the smaller population and get a more accurate estimate. And that rate in Kalkaska County is 12.5 deaths per 1,000 live births. All of these negative health factors link back to what we call the social determinants of health. And there's a growing understanding that health can't be addressed solely through clinical practice, but that there are social factors in people's lives, households, and communities that affect their health. And public health is one of the mechanisms that we use to identify and address these factors. Here are age-adjusted mortality rates for the 10 leading causes of death in Michigan in 2016. And we can see, once again, that Michigan exceeds US age-adjusted mortality rates for many of these leading causes of death. And then Detroit, in comparison, is far to the extreme. And these differences largely relate to the physical, built, and social environments and communities, as well as socioeconomic factors. Public health in the way that we've disinvested is an area quite like infrastructure, where after a long period of underinvesting, we're now seeing the grave consequences of that neglect. Not coincidentally, infrastructure is highly relevant to public health. Michigan faces around $13.8 billion in drinking water infrastructure needs, with additional needs for wastewater infrastructure. Road and bridge disrepair affects safety. The lack of multimodal public transportation impacts health, because public transit is something that is seen to enhance health in a variety of ways, by improving the environment, by encouraging walking, by connecting people to economic opportunities. And increasingly, broadband access is an emerging factor that affects health when we consider telemedicine, when we consider electronic health records, and general access to health and nutritional information, as well as the need of internet access to pursue employment and education, which are important social determinants of health. According to the governor's 21st Century Infrastructure Commission, the state's infrastructure system is interconnected with the health of our people, environment, and communities. Investments in communications, energy, transportation, and water networks and technologies support a pure Michigan that in many ways defines the character of our state. And we at the Citizens Research Council couldn't agree more. We see public health as a threat not only to our physical, social, physiological well-being, but also to the good of the state in impacting educational outcomes and workforce development, among other things. In conclusion, our report found that public health is a central yet broadly misunderstood function of government, and that in recent years, the state has invested little more than what was needed to draw down federal public health funding, leaving Michigan lagging the nation in both per capita funding for public health and measures of population health. Lastly, we find that more social investment is needed in public health to increase awareness and to increase partnerships that are increasingly necessary to address 21st century health issues. So a health in all policies approach should be adopted statewide, allowing government policy from schools to roads to criminal justice to include assessment of associated health risks and/or benefits. State and local health departments should also endeavor to coordinate public health across sectors and to elevate the public's understanding of public health. And with that, I'm happy to take some questions if there are any.
Thank you, Tim. We have had a few questions come in, but I certainly encourage others to type in their questions if you have any. Before I ask these questions, I want to remind everyone we get to the point where people start heading off. This whole webinar has been recorded. It'll be processed and put on our website. It should be up by 1 or 2 o'clock this afternoon. So feel free to come back, but we'll also send out an email letting you know and encourage you to share it with others who maybe didn't have the opportunity to tune in this morning. So the first question, Tim, how is it that Michigan's spending on public health has come to be so low relative to other states? Has it always been this way, or is this a reflection of our single state recession and the tough times that we've had in the state in the last 15, 18 years?
That's a really great question. Our analysis has been largely limited to 15 years looking back, and so that historical analysis puts us at sort of the start of Michigan's single state recession before the Great Recession. I can say that Michigan's public health code was pioneering and formed a framework for other states to adopt, as well as Michigan's coordinated system of state health department and local health departments. So there's evidence in the past and in Michigan's history of really high achievement in public health, and not only in those structural things, but also in the development of specific vaccines, or the fact that even the Salk polio vaccine was, its efficacy was announced at the University of Michigan in Ann Arbor. So Michigan has a really rich public health history, and it's really been since the reorganization in the late 90s that created the Department of Environmental Quality and the Department of Community Health and fragmented many of Michigan's public health services, and then Michigan's single state recession in the early 21st century that we've seen this waning interest. So part of that could be economic on the part of Michigan. We've had trouble paying for just about everything from our schools to our roads to pensions to support for local government and public safety. But on the other hand, it could be some structural disinvestment as well, that we now have Michigan's core of population health buried within the largest state agency that's largely responsible for Medicaid and other human service programs, where public health is 1% financially of what the department is doing.
All right. Question has come in: have health outcomes in Michigan trended along with the funding levels? For example, is decreased funding correlated with worse health outcomes relative to other states?
It would take quite a bit of study to make the causal claim that lack of investment in public health is directly leading to these poor health outcomes. The poor health outcomes we see in Michigan correlate more closely across all states with social and economic factors in the state. So the median household income, the average educational attainment or the number of college degree holders, as well as the spread of income inequality. So that can be measured by something called the Gini index, and the Gini coefficient more clearly tracks with health outcomes across the country than does state level investment in public health. Although if you look at our spread, there's some sort of general correlation that the states we think of as having poor health, such as Mississippi, are toward the bottom, and states that we generally think of as being healthy, like Minnesota, fall toward the top. But per capita investment in public health doesn't tell that whole story in terms of causation. What the health outcomes do tell us, however, is that we have a problem, and public health is the primary way to address that problem.
So here's a question that was like several that I received when we were talking to some radio stations about this with release of our paper. The crux of the question is, how do we move the needle on this? How do we get policymakers to pay attention and realize that there's a problem? The question that's asked, what are the best ways to help decision makers move beyond a 1 or 2 year budget perspective? Return on investment analysis will help, but there's the wrong pocket issue, as well as the fact they still have to pay for things that year.
Yeah, that's an ongoing challenge in many ways. I think the first part of the answer to that question is generating more public awareness. So when people talk about what they want the government to do, it's fix the roads or fund the schools or more money for local government. And so the public requests made to legislators from their constituents don't generally surround public health, because this is something that benefits everyone, but it's not a thing that we're actively paying attention to. And then when it does pop up in the news, from the hepatitis A outbreak in Southeast Michigan to Flint water to PFAS, it's presented as isolated pockets that don't connect to this underlying theme of public health. So on the one hand, generating more public awareness, I think, is important. On the other hand, I think that while more investment is certainly necessary, we can achieve better health outcomes and public health improvement through strategic mechanisms that don't necessarily involve substantial increases in appropriation. So that's when we get to health and all policies and more coordination with the private and philanthropic sectors outside of government. It's also important to note that our analysis of expenditure data in Michigan goes up to the fiscal year 2017, because that's the final year that we have access to those expenditures. But fiscal year 2018 did see an increase in public health appropriations. So it may be that the international attention on Michigan, particularly in terms of environmental health, as well as business concerns over viability of the workforce and disability, are finally translating into those increased appropriations.
Thank you. So here's a question that relates to the diffusion, the fragmentation of responsibilities. And I should say, before I ask the question, just to let the reader ask the questioner and others know, this is something, this topic is something we're going to work on over a number of upcoming papers. This is sort of the kickoff, and then we see a number of papers coming, and this particular subject is one of the things we want to dig into. The question is, a part of the problem that no single department is responsible for overseeing public health. How would you react to an idea of a czar of public health in Michigan?
I don't know how I feel about the term czar, but I think the chief health strategist term coined by Karen DeSalvo in Public Health 3.0 is a similar idea, that we need strong figures both at the state and at the local levels to coordinate public health. So whether that means recreating a Department of Public Health and pulling those services and specifically the regulatory authority back under an umbrella that's focused on public health, whether that means having, a sort of czar that's coordinating between the departments, or some other structure, is unclear. I think that there are obvious structural challenges right now where you have an agency or department like the Department of Agriculture and Rural Development that obviously does great work in keeping our food safe and unadulterated, but at the same time has responsibilities both for public health as well as for agriculture, industry, services, rural development, fairs and exhibitions. And so there are certainly conceivable instances where you could see the need to promote the agricultural industry and the need to promote public health coming at cross purposes. And so having a person that coordinates between environmental issues, agricultural issues, and other population health issues would be valuable.
Very good. This question occurred to me with the, to some extent, with the growth of Obamacare and the sort of healthcare for everyone. What is the role of our local health department? So the question that's asked, is there a role for public health departments to provide direct services? For example, dental, pediatric care, STD diagnosis and treatment, even immunizations. Or would it be more cost-effective and higher quality to provide state funding and support to the federally qualified health centers? There are community health center locations in all counties. That way the health departments can focus on other functions that are not done by any public entity.
Yeah, that's a really good question. And until universal access is achieved, so we still have roughly, last time I looked, about 6% of the population is uninsured, and others that have diminished access to clinical care and health insurance. So until we reach that point, eliminating immunizations and other direct services from local health departments could put certain populations at increased risk. But in the long term, I think a greater coordination of public health with our system of primary care delivery, and is including those federally qualified health centers that are so important to extending access to at-risk communities, is definitely the way to go. And that seems to be the way we're moving.
Another great question here, something that I've asked as we've done this project. If we put another dollar into public health, what does it buy us? And the question that's asked, if we were to see an additional influx of financing for public health, what sector of public health should we as a state invest in first? maybe it's a little premature to ask that question given our plan to do more, but let's get Tim's thoughts on this.
Yep, that's another really great question. And I think the answer to that would depend on if your primary concern is bolstering what we're already doing to enable potentially faster and more coordinated response to emergent health issues when we have an environmental contamination or when we have a infectious disease outbreak, or if the goal is to think more strategically. And I think with regards to the former, it's my sense, and I need further study on this admittedly, but it's my sense that better coordination and organizational structure issues can address some of the former, and so new investment really should be focused on needs of the future, which include addressing chronic diseases more visibly and integrating into communities to address social determinants of health and the health inequities that we're seeing in our state, because those factors are growing and we're seeing a wider span of split in average life expectancy between particularly the most affluent communities and the least affluent. And so that's a growing need, and particularly with our aging population in Michigan, that's a sensible place to invest.
So we're going to make this the last question. The witching hour is approaching, and we advertise this. We would get it done in an hour, so we'll make this the last question. This was a question again that I received from talking on the radio, is sort of connecting the dots. We hear about what's wrong with the Affordable Care Act, that cost of medicine is still going up, cost of healthcare is still going up. So let's connect the dots. How does investment in public health translate to the cost of health insurance and the cost of receiving health services in Michigan? Because we're not doing these preventive things, they result in adverse health consequences and higher cost in the back end. You can pay me now or you can pay me later, sort of a thing.
So let me preface this answer by saying that Michigan has amazing healthcare providers and physicians, as well as health facilities like our hospitals, and they do fantastic, important, critical work that benefits all of us. That being said, there's a classic sort of public health cartoon that shows two people in surgical scrubs with mops furiously mopping the floor as it's being flooded with water, and in the background behind them is a faucet that's turned on and overflowing, the point being that no one thought to walk back and turn off the faucet. And then you wouldn't need to spend so much furious effort mopping up the outcome of that oversight. And so when we talk about reducing health disparities and addressing social determinants of health, as well as physical and really any societally based structural determinants of health, investing in those factors would necessarily lead to a reduction in utilization of healthcare services. And in the report, you'll see there's a discussion specifically with chronic diseases and the cost of chronic disease, and the fact that when we look at our national health expenditures as a proportion of GDP, only about 3% of that is invested in public health. And given the rate of growth and the cost of medical care, which exceeds inflation, holding steady, the proportion devoted to public health will decline. Admittedly, interventions at the community level and health promotion is challenging. It's difficult to overcome people's environment, people's habits as it relates to behavior, but there are certainly tested and empirically proven strategies to do so. And so investment makes perfect sense as a way to reduce our long-term cost in healthcare. If you look at Europe, most health systems have a population health focus, so integrating public health into our healthcare sector, as well as having a stronger strategic government role in coordinating those services, is what we need to be doing.
Very good. Thank you, Tim, for your insightful comments. I encourage everyone, if you haven't already, to come find the publication on our website, crcmich.org. Before I go, I want to do some cross advertising. The election is approaching in November, and as you probably are aware, we have a few ballot questions ready to appear. So we are doing our usual work, analyzing those questions. We expect in about 2 weeks' time that those will start to roll out. So watch for those coming out. Again, we'll be doing webinars to talk about those. And let me just finish by thanking everyone for their attention, signing up and coming. We had some great questions, so thank you for those. And everyone have a glorious day. Hopefully the weather shapes up a little better than it has been. A little hot and sticky. So thank you all and have a great day.